Hi, I'm Tim Hughes from Adelaide, Australia, and talking at SOHO 2016, focusing on the future directions in CML. And really, for this talk, I concentrated on the future prospects of treatment-free remission. Two important studies recently presented, one of them the ENESTfreedom study, in which patients who had been treated frontline with Nilotinib and had at least 3 years of therapy and had achieved an MR 4.5 and maintained it for 12 months. We now have the 48-week data on these patients, and around 50% are maintaining treatment-free remission. This is, I think, quite good, particularly when you note that the median Nilotinib duration was just 43.5 months, so much earlier than the duration of the TKI therapy and all the other trials we've done so far. Just as important, the patients who had to restart their therapy had nearly all those patients re-achieved major molecular response, and over 80% and almost 90% have so far re-achieved MR 4.5. The other important study recently presented was the ENEST-STOP study, in which patients who had not been able to achieve a deep molecular response on imatinib were switched to Nilotinib, subsequently achieved MR 4.5 and maintained it for 12 months, and then were able to stop therapy and were watched closely. And once again, we see this typical pattern of patients needing to restart their therapy, but in this case, almost 60% maintaining major molecular response on no therapy out at 48 weeks. Note that the median follow-up in this study was more in line with the other TFR studies of 87.7 months. And once again, very good re-establishment of a deep response for those patients who go back on their drug. The very large European registry study, EuroSCI, was also presented. And once again, the outcomes have looked very good. 49% treatment-free remission rate out at 3 years. Important to note that in this very large study, not a single case of progressive disease or CML-related death. So based on these, I think, very encouraging studies in terms of safety and efficacy, we recently, myself and David Ross, published a Perspectives in Blood in which we suggested we should be moving this into mainstream clinical practice. This can be done as long as the appropriate conditions apply. And firstly, we talk about institutional requirements, and that is that you have a precise and a sensitive, standardized PCR assay, that you're able to apply it to your patient if they stop therapy on a very regular basis, 4 to 6 weekly, that you're able to see those results within 4 weeks, and that you're able to monitor those patients closely so that they can go back onto their therapy as soon as they lose major molecular response. If you're able to do these things, then treatment-free remission becomes a possibility in a mainstream clinical practice. But equally importantly, the patients where this can be offered need to be carefully selected. And we set this out in a green, yellow and red traffic light type table, in which if the patient ticks all of the green boxes, it's appropriate to talk to that patient about the possibility of treatment-free remission. If they tick any yellow box, that would only be appropriate in the sort of high need settings such as pregnancy or significant toxicity. And if they tick any red box, it would not be appropriate to consider TFR outside of a clinical trial. So importantly, we see in the green box, including criteria that the patient has the typical transcript, that they have had only chronic phase during their entire history, that they've had optimal response to therapy, that they've had at least 8 years of TKI therapy and have maintained MR 4.5 for at least 2 years. In that setting, I think it's appropriate to talk about TFR with your patient. So in conclusion, maximising treatment-free remission represents the major challenge in CML in 2016. We now have data on over 1,000 patients demonstrating the safety and the efficacy of treatment-free remission attempts under the appropriate conditions. The challenge now is to make this a mainstream approach while minimising harm to patients. And it looks increasingly likely that the more potent tyrosine kinase inhibitors offer the greatest prospect of expanding the TFR population. Thank you for your attention.